Hello, and thank you for inviting me to speak today about health equality as pertains to pharmacogenomics. Pharmacogenomics is a very exciting concept with the promise of taking a more individualized approach versus a traditional one-size-fits-all to therapeutic prescribing, where we can use genetic information to make a more informed choice about therapeutic choice and initiation and titration of dose, and thereby has the promise of increased efficacy, decreased unintentional toxicity, encouraging increased compliance, and a more targeted approach to dose titration. So it all sounds great, but there are some caveats. So the prevalence of different genetic alleles can vary between populations of different ancestry. However, there's more genetic variation within a given population than between different populations. There's also increasing admixtures of different populations, and genetic studies use a self-reported race or ethnicity and often conflate the two. And the definitions from study to study of what either race or ethnic categories are is really heterogeneous. So it's quite difficult to compare, and some standardization probably would be very helpful. So an example of pharmacogenomics in action, carbamazepine, which treats seizures, trigeminal neuralgia, bipolar disorder, but unfortunately also has the potential for very severe adverse cutaneous reactions, which include a spectrum of Stevens-Johnson syndrome and toxic epidermal necrolysis, which have a significant mortality rate. So we know that the HLA-1502 gene is associated with a higher risk of this kind of severe allergic reaction, the Stevens-Johnson syndrome and toxic epidermal necrolysis, particularly in those with Han Chinese heritage. And so the FDA quite sensibly recommends testing. So when we look at the FDA label, what do we see? So essentially, they say that the variant that's, we've discussed the HLA-B1502, which is associated with a risk of developing these more severe reactions, is found almost exclusively in patients with Asian ancestry. So it's recommended that all of these at-risk patients should be screened. And if they are found to have this allele, then they really shouldn't have carbamazepine unless you can say absolutely the risks are outweighed by potential benefit. But how do we say then who is at risk, who has Asian ancestry? Is that a box that someone ticks? Is it something that we decide looking at the patient? I think we can see that there's actually a sociologic and identity component of this, which is not really as straightforward as the label suggests, and where perhaps a self-acknowledged definition of race or ethnic heritage may not coincide with may not be a good proxy for genetic risk. But pharmacogenomic benefits we want to be equally accessible to everyone. So what's the rub here? We know that generally there's healthcare inequality, unfortunately. So if we look at stratification via racial, gender, or socioeconomic class, we know that healthcare outcomes are not equal, sadly. And so when we think about pharmacogenomics and adding an additional layer with genetic information here, we want it to be something that decreases that inequality gap, not increases it. So obviously we want to think about what would broad implementation of pharmacogenomics do in this regard? Would it be something that addressed and minimized inequality that already exists, or would it be something that could perhaps exacerbate the underlying problem? Unfortunately, it's not yet clear. There hasn't been broad enough implementation, and there hasn't been a lot of work looking at healthcare inequality outcomes with regard to what is implemented. So the concept of social justice is paramount. Unfortunately, most genetic studies generally, and specifically pharmacogenomic data, don't adequately address very admixed populations or populations including minority ethnic backgrounds, including notably Indigenous peoples. And unfortunately, some of that is because relationship of the mainstream research academic community and institutions with some ethnic minority groups has been really fraught with mistrust based on ethical breaches in research in the past. So some very well-known examples of that, which I'm sure you'll all be aware of, is the Tuskegee study in the United States, where syphilis was left untreated after the availability of penicillin. The case of the Havasupai tribe in Arizona that had perceived their consent for genetic study to be around risk for diabetes, and instead research was produced which discussed quite stigmatized topics, including mental health problems and some migration studies. And there's another example, which I think you'll all be aware of, which is Henrietta Lacks, which we know now about HeLa cells, was a woman with cervical cancer whose cells were unfortunately used without her consent or knowledge, first for research purposes and then for commercial purposes. So we can see why not all groups of people might be very forthcoming with consent to participate in research studies. So is there a risk then that this lack of representation and inclusion on the research level could result in health inequality later down the road if pharmacogenomics is widely implemented? And unfortunately, I think the answer is yes, it is possible. And so we do need to consider that and have more inclusive research. But there's some difficulties with more inclusive pharmacogenomic research. We talked about the distrust between different communities and researchers, as well as the heterogeneous definitions of race and ethnicity. And race is really a social construct, not a biologic one. So there's some sociologic and identity concerns at play here as well. And that make really the conflation of race with ethnicity not super appropriate. The concept of admixture is problematic, firstly because it implies that there's pure genetic populations, which is not true. All populations are admixed, but also because heavily admixed populations haven't really been included in a lot of research to date. Crucially, there is an important role of genetic ancestry in genomic research, so this is all quite complicated. And could all these problems result in potential eligibility criteria for testing or therapeutic algorithms, which include a racial stratification? I think that could happen, and that would be potentially problematic. There is the concept of distributional justice in pharmacogenomics. Who could afford this? Would access be equal regionally? So if you're in a very big tertiary genomic center in the UK, would you have the same option as if you're in a district general hospital in a very rural place? And with different insurer systems, would access be equal between private paying systems and national health services? And really, what is that acceptability? What would people want to pay for, either within a national health system or within a private payer insurance system? So health economic studies are ongoing. When we talk about health economics, we're weighing the cost and the benefit, which is a bit difficult in this case because there's some uncertainty with regard to both the cost of full implementation of pharmacogenomics more broadly than the few examples used now, and with regard to the potential benefit of that. But so far, the majority of studies do say pharmacogenomics would be cost effective. The threshold for that, I think, would be higher within a national health system. So you'd have to prove that actually that's a really good use of money, which is better than other uses of money. We should also consider language barriers and barriers in terms of scientific and genomic healthcare literacy. So we already know that people who don't speak the primary language have poorer health outcomes. So in England, people that don't speak English well have less favorable health outcomes. We also know that those with less healthcare literacy are less able to advocate for themselves. So we, again, want to be mindful that pharmacogenomics implementation would not leave these lagging groups further behind. So there would need to be a threshold level of accessibility. we need everyone to understand that, you know, a genetic test for an allele which would help with therapeutic choice is not the same as a genetic test for Huntington's disease, for example. So ideally, there wouldn't be a racial component of eligibility for pharmacogenomic testing or in therapeutic dosing algorithms. We would instead use genetic markers of ancestry and stop including discussions of race. We would also ensure equal accessibility both regionally and across socioeconomic classes, so everyone can afford the same level of testing and everyone has access to the same level of testing. And then we would need to make pharmacogenomics accessible for everyone, and that includes those facing a language barrier or a barrier of genomic or scientific literacy. We need to build trust with communities that historically have had less engagement with genomic research. And we need to thereby make genomic research much more inclusive. And really importantly, there needs to be ongoing real-time assessment of the impact of pharmacogenomics implementation on health inequality and health equality as pharmacogenomics is implemented. So I think this is a very exciting area. It is important to prospectively consider all of these issues. And I look forward to seeing pharmacogenomics in action. Are there any questions? So if anyone has any questions, we can discuss in the group chat, or you can contact me via email. Thank you.